Welcome, everybody, to Healing at Home. My name is Dan Gorenstein. I'm the executive editor and host of Tradeoffs, a nonprofit health policy news organization. A little bit about us. Our podcast launched in 2019. We've produced more than 160 episodes. We've had over 2 million listens to our entire catalog. And the thing I like to say most is that we've had more than 50 colleges and universities use our content in their classrooms. And so the line is, we are in the ears of the future leaders of the US healthcare system. Our mission is to help people have smarter health policy conversations, which is exactly what we're doing today. We cover all aspects of health policy, from drug prices to reproductive rights. One of our themes is issues facing older Americans, which this event is part of. And I would like to very much thank the SCAN Foundation for their support of this work. Thank you. We just released a podcast episode just yesterday, actually, about hospital at home. 2.5 years ago, there were only 20 hospital at home programs in the country. Today, there are 277 across 37 states. And thousands of patients have experienced it. One of them is 70-year-old David Mercurio from Central Massachusetts. Here's some audio of David from our episode.
But this is the way I looked at it. They're going to give me the same treatment that they're going to do at the hospital. And I trusted them in the hospital, so why wouldn't I trust them there at home?
I really like that clip of tape, and I do because it grounds us in what we're talking about today at the highest level: safety, trust, healing. In what way could there be bigger callings than those things? To be clear, this conversation is in part about hospital at home, but it's broader than that. It's really about the whole continuum of care, of home-based care. To frame the session, there are two questions I want us all to be thinking about. The first is, what lessons have we learned about home-based care thanks to the explosion in hospital at home over the pandemic? And the second question is, how do those lessons inform the opportunities and challenges of home-based care going forward? One final super important note: while we know that our featured guests, of which there are 4, have a lot of insights, at Tradeoffs, we also understand that you all in the audience have a lot of experience to share too. This conversation will be interactive, so fair warning, be as ready to answer questions as you are to ask them. And we're actually going to do that right now. We're going to start off what we're talking about. And I'd like to get a sense of who is on the call today. And I'd like people to respond in the chat function to a simple prompt. Please share 2 things: your job and 1 adjective about how you feel about home care right now. And I'm going to open up the tab if I can find it. Here we go. Chat. Okay. I am okay. I see Laura C. Hart, the Director of Online Educational Initiatives, is here. Taki, Medical Director of UMass Hospital. You're feeling very optimistic about ongoing advancement of home-based care. Laura, to your point, you're feeling hopeful. Very good. Wow, lots coming in super fast. Oh my goodness, super cool. I see Megan, Clinical Manager, Innovative. Evelyn, if I'm pronouncing your name right, I hope so. The Future of Medicine. Andrew, the CEO of Home Care, Difficult. Very good. I really appreciate this. And, keep that. We want this to be interactive. And so feel free to engage in the chat and talk to each other. Hopefully people will get to meet each other and have after this event, you'll have a way of, you will have met someone else, and that's going to inform your choices and decisions going forward. So some of those emotions, optimistic, difficult, are a range of emotions that 2 of our featured guests have grown familiar with over the last few years. And we're going to introduce them now. We're going to start with Bruce. Bruce, could you please introduce yourself, your title, your short title, and tell us about you? And then I've got a question or 2 for you.
Sure, Dan. It's great to be here. I'm Bruce Leff. I'm a geriatrician, which means I'm a physician who specializes in the care of older adults, and a health services researcher who's worked for a long time on developing, evaluating, and trying to get into practice innovative models of healthcare delivery, most of which are happening in the home setting and the community setting. And I've been on that journey for almost 30 years. And I'll just call out my mentor, Dr. John Burton, who I saw his name in one of the Hollywood Squares today, who got me interested in all of that. So I thank John as well.
Thanks for that, Bruce. And a big picture question for you. Bruce, in your mind, what are the two biggest things that we've learned about hospital at home over the last 2.5 years? In other words, what do we know now in your mind that we did not know when you and I did an interview about hospital at home back in May of 2020?
Right. So I think it's a great question, Dan. So one thing we've known about hospital at home for a long time, over 30 or 40 years of research, is that hospital at home, delivering acute hospital level care in the home, is something that can be done. It can deliver high quality care. The care can be associated with fewer complications, especially for older adults, which was the reason we got into it. Could cost less. And I think the two big things that I've walked away with is, just how much a crisis such as the COVID pandemic can help to move things forward, and just how important it was to have a change in the way that Medicare paid for hospital at home. That is, before the pandemic, in traditional fee-for-service Medicare, there was no payment mechanism for hospital at home. And despite decades of excellent research, it really hadn't caught on. There may have been 15 or 20 programs around the country. Then with the pandemic and the Medicare program and the administration appropriately concerned that hospitals were facing a capacity crunch, creating a payment mechanism for it really got the model up and going. As you noted, now 260 plus hospitals have applied for and received permission from the Medicare program to bill a traditional hospital payment for hospital at home. And that's really helped the model, grow exponentially. So, the influence of crisis and the influence of payment on the ability to promote culture change and change in leadership. And I think the corollary is just how much pent-up demand there was in health systems to get started with hospital at home. So those are some of the big takeaways for me.
Right. And so just to try to restate that for a quick second, you're talking about this pent up demand. So one of the things that you feel like as an expert in this, as someone who has studied this for decades now, you feel like one of the things that is clear that we know now that we did not know in May of 2020 is that lots of people, lots of hospitals, lots of health systems around the country actually wanted to dive in.
Exactly. So, and I think the other really important thing to think about there, so, I've been having conversations with health system leaders for 20 years, trying to get them interested in hospital at home. And many said, we'd really be interested in doing this if there was a way to pay for it. And sometimes you're on those calls and you don't know whether someone is just trying to be nice to you and get you off the phone, or whether they really mean that. So I think it shows that they really mean it. And I think another dimension to that is that when the payment came along, the payment was a temporary payment. The system for payment was only to last as long as the public health emergency lasted. So systems were jumping in with both feet, with the understanding that the payment was not permanent. So kind of like a Cinderella, right? If the public health emergency was declared over, the payment would go away, like Cinderella at midnight. The coach turns back into a pumpkin, and the beautiful dress turns back into rags. And that was the case until the omnibus bill was passed by Congress at the end of the year, which extended that payment now through December of 2024. But understood, it's not a permanent payment. It's not a permanent feature of the Medicare program at this moment.
Really appreciate you laying out some baseline information for everybody on the call. Some people know this stuff, some people do not know this stuff, and hopefully this is an opportunity, this call, for some of us to kind of get more up to speed. And I hear you, Bruce, you're saying that this is in fact not guaranteed. Hospital home funding is not guaranteed going forward. Mona, I'd like to have you introduce yourself please, if you could tell us again the short version of the title and what that actually means.
Yeah. Simona Siddiqui, I'm an internal medicine physician, and my job at Humana is to really grow our ability to care effectively for patients in the home setting. As one of the largest Medicare Advantage plans, we're really committed to making sure that folks have access to the best available care in the right setting for them.
And Humana, for those of you who on the call who might not know, Humana is one of the nation's largest health insurance companies. And so, Mona, the question for you, as you're thinking about how to deliver care across the continuum in the home, two questions. We'll break it up one at a time. What do you like most about home-based care?
Yeah, I mean, fundamentally, I think being able to receive care in the home as a patient provides an enormous amount of dignity. And I think it also really cares for patient preferences. In the hospital setting, I think the dynamics are such that it often feels like care is happening both from a patient and a family perspective. Care is happening to them, or things are happening to them rather than with them. I think having care be delivered in the home can really address those dynamics and level the playing field, but also really care for those patient preferences.
And I know I've got I have to ask a follow-up before we get to the second part of this question. When you say care, it's very sort of a provocative thing to say. Care is happening to them. You are yourself a doctor, so you've been on the delivering end of that. What do you mean when you say care is happening to them?
Well, so I'll share a personal experience,
Please.
less now from the provider perspective and more from the caregiving perspective. I was caring for my grandmother in the last days of her life. And she was also a physician. And so we sort of knew what she wanted. And she wasn't getting the kind of care she wanted. And there was not sort of that engagement. And again, it was towards the end of her life. And so I think more of it was being decided by folks surrounding her rather than shared decision-making between her and us as the family. And so we brought her home. And I think we're really able to give her the care and the experience that respected her and respected her choices in the setting that was really where she felt most comfortable. That was where she wanted to be. Now that's not without its challenges, but I think it allowed us to, again, care for her dignity and her preferences while also making sure that she got the level of care that she needed.
Feeling like she finally, and you as the extended family, had a voice.
That's right. That's right.
And so thanks for sharing the personal story, Mona. I really appreciate that. What do you like least about home-based care?
So, I think, and again, this is based on some personal experience. I think the amount of coordination and logistics that are required to make it effective are enormous. So the coordination when it comes to kind of who's coming in the home, when they're coming, the monitoring technology that's required to be in place. And then frankly, the burden on the caregiver and the family as well to ensure all of those pieces are working in sync. Again, I'll share personally, I've gone through medical training and residency, and I've had 2 kids during residency. For me, there was not ever a more physically and mentally grueling time than being one of the lead people caring for my grandmother in the home. And so I think while the promise of it is there, especially if you can make it work effectively and have all of those pieces coordinated, I think the burden on the caregiver and the family can be enormous, and that is something that we have to solve for.
Well, I really thanks for previewing. We've got another guest coming up later in the call who has some perspective on that too, and maybe the two of you can talk a little bit and sync up. I'm really curious about, April, what you might have to say to some of what Mona just said. that said, for the time, thank you for that, Mona. I want to really turn to the audience right now. And we want to hear about what you all have learned about home-based care. This time, rather than in the chat, I'm actually going to ask you to raise your hands in Zoom, something I frankly, until this week, all the prep work, I didn't even know how to do. So I'm going to give folks some instructions real quick. So for those of you who might not know, first, click on reactions. It's in the toolbar at the bottom of your Zoom window. Then select raise hand. And when we're ready to go to you, we will ask you to unmute and then you can share your thoughts. Now, here's the question. In your experience with home-based care over the last 2 years, what did you learn? What worked well? What did not? And while people are giving that some thought, many of you responded to a very similar question when you signed up for this event, and thank you for doing that. And I want to read one of those right now, and in advance, I may mispronounce your name, Pawar Vibat. I'm sure I got that wrong. I apologize. But Paravi's Bat's mother had home care in her final months, and she says, what worked was compassionate care in women who truly cared to be in this work. What did not work, she says, is we are Indian American immigrants. There is little cultural knowledge or appreciation for different cultures and faiths when at home. Really appreciate that. And again, I am so sorry for, I'm mispronouncing your name, I'm sure. And maybe we'll have a chance to hear from you and you can correct me. But thank you very much for sharing that thought. That's a really important one as we consider this. Okay, looking at hands, I see Donna, you have your hand raised if you want to go off of mute.
Yeah, I'm not sure you can hear me though.
Yeah, I can hear you loud and clear. And just as a reminder, real quick as a reminder, the question is, in your experience with home-based care over the last 2 years, what did you learn?
Well, in home-based care, my husband is a quadriplegic, and the most difficult thing that we have had is we live in a rural community, and access to care here has been very difficult because with the shortage in staffing throughout the community in general, he needs skilled care. I'm a registered nurse, and I am also getting old now and need support in his care. We almost cannot find resources. Resources don't come out to this neighborhood. They don't supply in this rural neighborhood at all. So I am having to do all of his care. And so I can't get nursing RN staff, skilled staff to come here, and I am having to train people to take care of him. So resources are almost non-existent.
And thank you very much, Donna, for sharing that. And I'm sorry that that is experience that you and your husband are having. Can I, real quick, where is it you all live?
We live in King William County in Virginia.
Okay. Okay. And what do you feel like? So are you and your husband glad that there is more care being delivered in the home? Does that seem like
Oh yeah, definitely. We've been doing home care for a long time, actually. We've got some wonderful physicians who work very closely with me because I don't want him in the hospital. There's too many germs there. So as much as we can, I have basically a critical care hospital I run out of my home because he's got some very complex medical needs, and I do most everything for him. I have a suction machine. I have titrations for high and low blood pressure. I do all types of things here to keep him out of the hospital. So I run a hospital here.
Got it.
But it's great. I love it. But I can't get access to lab work. I can't get access to sometimes the rescue squad because they're not close by. And that's where the complication comes in, is the extra support that I need.
Got it.
And even getting access to the doctors in time when I try to call into the hospital. I make a lot of independent decisions.
Thank you, Donna. And I want to kick this. I want to kick this to both Mona and Bruce. I'm curious if you guys have thoughts and reactions. If you've heard stories similar to Donna's, and the perspective less from the patient perspective, but more from the system perspective, both the provider, the healthcare system. Bruce, are healthcare systems aware of these sorts of challenges, and are you hearing, as you interact with health systems around the country, how are they trying to respond, particularly in rural areas as Donna lives in?
Yeah, so and just to call out, so appreciate Donna's story a great deal, and sorry for the trouble Donna has been having in finding skilled people to provide care. Also, just to put a pin in the idea that I think we've talked about hospital at home. I think Donna's talking about what is called skilled home health care, which is a Medicare benefit that provides potentially ongoing but episodic nurse skilled therapy, like physical therapy and occupational therapy in the home. There have certainly been challenges for health systems in more rural areas to have people to deliver skilled home healthcare. So Donna's story, as terrible as it is not entirely surprising. I do know health systems in rural areas have been working very hard to find those people. I was just on a call yesterday with a system in rural Arkansas that was talking about the same idea, but at the same time talking about the possibility that hospital at home could help to provide an infrastructure to develop pretty sophisticated supply chain and logistics that Mona was referring to, that could help span a full range of care in the home. So long-term services and supports, home-based primary care, home-based palliative care, skilled home health care, hospital at home, rehabilitation at home, in the service of trying to come up with more of a continuum of home-based care. But that's sort of for a future thing, and hopefully we'll get to talk about that. But I don't think Donna's experience is unique in the rural space, and I do think it's a high priority for systems to develop that workforce. Workforce has been a challenge in the residue of the pandemic, for sure.
Thanks, Bruce. And briefly, Mona, I'm curious, from the payer perspective, is Humana taking any specific steps to try and encourage providers to provide more of this care, particularly in rural areas?
Yeah, so a couple of things. One, obviously, Humana has the insurance side, which I've been a part of for many years and have recently moved to the care delivery side. So we also now have the largest home health agency under the Humana umbrella. So are deeply familiar with some of the challenges that Donna is talking about. And the staffing shortages that we're all grappling with are obviously tremendous. The other thing I'll say is that Humana in particular, we have a fair amount of presence in rural areas. So we are in an insurance provider in many markets that are underserved by providers and by physicians. And so thinking about how do we provide our services to these patients. And I think there isn't a simple answer here, but I think what we need to see here are partnerships between a Humana, home health companies, health systems, because no one entity can do it on its own. So it would be really hard for a health system that is trying to just care for patients in its four walls to also think about how they extend into the community, again, given the thin resources right now. I think it makes a ton of sense for all of us to be partnering to say, what are the needs of these communities? How do we address those? And how do we create a model that can be replicated in other markets, again, where those shortages are continuing to persist?
Thanks for that, Mona. And if you have any additional information about those partnerships, or if there's any modeling around that, it'd be really interesting if there might be additional information to share with folks, because that I could imagine folks being interested in that and understanding what Humana and more largely the health insurance industry is trying to do to forge those partnerships. That could be good resources that we could share with people after the call. But thank you for that. Thank you for that answer. I'd like to go to Melanie Mercurio now. Melanie is someone with personal, like Donna, personal experience here in home care. She's been married to David, who we heard from at the top, for 47 years. And Melanie helped care for David during his 8-day hospital at home stay. And we should say, and this is wonderful news, that David has recuperated nicely from that tick bite that landed him in the hospital at home program. Melanie, the question to you is, and I'm hearing a little bit of feedback. I don't know if there's anything that can be done on that on the technical side, but just flagging that. The question to you, Melanie, is one of the big questions people are grappling with is what's the right role for a caregiver? And I'm really curious, in your experience, what was your understanding of your role, Melanie? What were the doctors and nurses expecting you to do?
My role was to certainly, let's start off with the monitor device, the tablet that they provided. They were there 24/7 if I needed anything. But the nurses who came in initially went over things that I needed to do when they weren't there. And they said that our doctor would be on hand whenever I needed him. And there was a doctor there on hand. I only needed to call probably once to ask a question at night. And it so happened that the physician that my husband talked to every day, he was the one who was on. The monitor would say, at such and such a time, you're going to do blood pressure. And he had also a wristband that monitored his vitals so that if something was off or they would call right away and say, gee, why aren't we receiving any information?
Right.
And, it would either be on the charger, getting charged in the morning. The nurses were absolutely fabulous, though, I have to say. I mean, the physician, that goes without saying, he's tops. I would want him again. He was unbelievable. But the nurses, they're there right with you. And if there's anything you don't understand, they would go over it and over it until you did. There was nothing that was that difficult, though, to understand. I know that I've been in the health field for many, many years in various departments. So it might be a little easier for me. However, they were there at the drop of a pin, whatever we needed.
And Melanie, I think the thing, you and I did a background conversation a couple weeks back, and one of the things that you said to me that really stuck out was that you were okay with this, but the truth of it is you had to do more. Hospital at home means the caregiver has to step up in a way compared to being when the loved one is in the hospital. Is that a fair characterization?
Absolutely, yes.
And
Because
and so go ahead.
Because we are now the ones that they're not in the hospital anymore. So there's no more people coming in and out to do vitals or whatever, or help feed him or it's me. And that's fine. But that's what was more on my plate than if he wasn't on that at home.
If this is going to work, if, more home-based care is going to be happening around our country, in your mind, Melanie, what needs to really happen? What do the doctors and nurses have to do to make sure people like you and other people who have less medical experience than you do actually can do what they need to do to step up and provide that care for their loved one?
I think that they need to be willing to do it and to learn. I can't see a very elderly person who lives alone. That might be a little difficult with nurses coming in AM and PM, what happens with them during the day. So they probably wouldn't be a candidate for it, for the hospital at home program. However, that said, it seems to me the average person without any clinical experience could get through this without a problem.
Okay. Well, Melanie, I thank you very much for sharing your experience. And I also just want to call out, while David has recovered nicely from that tick bite, which is why he was in hospital at home in the first place, David has another very serious health condition right now. And Melanie, you could be doing lots of things. You got lots of responsibilities, and you chose to take some time to spend it with us. And I just want to thank you. And I want to say, I really wish the very best to you and David and your entire family.
Thank you so much. And I did take the time because I believe in this program so much, so that I did set this time aside and crossed my fingers that the date and time would work so that I wouldn't have to bow out.
Right.
Thank you to everyone. Yes.
Thank you very much, Melanie. And you have a beautiful kitchen. Love that kitchen. Love the tile, the blue. I love this fantastic tiles. Okay. I'd like to turn now to that second question at the top, which is really sort of focused on the future of home care and important issues all of you are grappling with. There are a lot of people on this call, and they're on the call because you care about this, you're interested in this, you're worried about it, you're excited about it, you're all across the spectrum, but there are things that are happening in your lives right now that are connected to this. And so we want to deal with some of that. And I'm going to start with Bruce and Mona. And Mona, we'll go to you first. As you look ahead to the next 5 years, Mona, what's just one challenge that you think is facing home-based care?
Yeah. So I'm going to put two together that will hopefully be quick, Dan.
Okay,
so
go for it.
First, I really do think that we have to mature as an industry in our understanding of what it is that we're trying to solve for. And what I don't want to have happen is for home-based care to be used as a blunt instrument to solve all of healthcare's issues, whether it's rising cost or poor patient experience, because I think we'll do home-based care a disservice. And I think there's an open question, and this is sort of the second point, about the ability of home-based care to really scale. And so I think in the next couple of years, what's really, really important for all of us is to get really sharp around what's the right patient population, at least for the initial period where we want to focus, and make sure that we are getting the model components right, both from a clinical perspective, the technology that's needed to be in place, the caregiver support that we need, and what's the system that we design that can be not just local in one region, but that can scale, and that home-based care can begin to answer that question and skepticism around the ability to scale. And I think once we do that, I think a lot more people will come to the table, push for adoption of home-based care. But I really do think let's not have home-based care be the solution to everything all at once, and let's really figure out how we design a system that is able to scale effectively.
Thanks for that, Mona. And to match your double-barreled answer, I'm going to hit you with a double-barreled question, which in journalism circles is frowned upon. When you talk about the right patient population, I'm curious, one, is there agreement, at least among insurers, but if you want to include providers in that too, that's fine. Is there agreement around who that right patient population is? That's part one of the barrel. The second barrel is who are those people? And even if there's not agreement, who do you think those people are?
Yeah, I would say that there should be general agreement. I think we have to, like I said, sharpen that. So what I mean by that is we obviously know the patient population right now that is going into skilled nursing facilities, right? And I think that there's a substantial portion of those patients that we could think about caring for in the home. And I think patients who are post a cardiac event, or have chronic obstructive pulmonary disease, so lung conditions, patients who have more serious wounds and infections. I think there's a population that we can really think about shifting the care into the home and beginning to design that system around those folks. I think the other question is, can we create a system where more folks like Melanie are willing to sort of say, yes, I want to have my family member get care in this kind of system. But I think we have an understanding of that patient population. Again, though, I think the challenge is that we've cared for those folks in the home in pockets. And it's not that I think we don't know what the patient population is. It's to say, can we do this in a way that more people can have access to the system, rather than it being, constrained to one segment.
Thanks, Mona. And Bruce, I'm just very quickly, if you could say this in just one sentence, and then I'll ask you your one big issue. What patients are not good candidates today in 2023 for whatever kind of home-based care? Who shouldn't be being treated in the home?
I don't think that office-based, say, ambulatory, typical outpatient care is going to go away, and it should not go away. And I think for folks who are able to easily get to an outpatient center for ongoing longitudinal care, that's great. They should not be the first target for home-based care. On the other hand, we have, sorry, two sentences.
No. I just want, you used some big words there. Like, give me one or two conditions. What do you actually talk like when you say ambulatory? Like, give us a composite of the type of person you're talking about.
So probably someone in a salmon-colored jacket and a blue shirt who's standing up and doing a radio show, looks like the kind of guy who could get in to see his doctor as a typical going to that doctor's office. And you would not be my first target for, say, home-based primary care. On the other hand, there are about among people who are Medicare eligible, there are about 2 million people who are completely homebound, like they never get out of their house. There are another 5.5 or 6 million who cannot get out of their house without difficulty or without the help of another person. So you have almost 20% of, that's about 12% of Medicare beneficiaries who really cannot access care. Those are folks who end up in the emergency room and in the hospital without ever seeing a doctor to get their many chronic conditions managed, who have who are functionally impaired and can't get out. Those are the people who really do need home-based care of all types. And I thought Mona's comment on the need to get big and integrate and scale is correct. And I would just add to that, I think it was implicit in that argument, but just to call it out, this notion of integrating these services so they're all not sitting in their individual home silos, such that we could actually build the care model around the patient instead of around, with respect, the payer or the doctors or the person who runs this program or who runs that program. It should be integrated, it should be seamless, and to the patient, it should just feel like one thing. And it should all come together. That's a big deal. We do not even have that in our traditional outpatient facility-based care world, where everyone's operating in their own silo as well. But I think that would be a great vision. And I love Mona's comment about not laying every single ill of the many of our health systems at the feet of home-based care.
Yep. Great. Thank you for that. And just a housekeeping note for folks. This call was scheduled to go until 2:45 Eastern. So in about 5 minutes, wrapping up. The conversation is going so well, and we have a couple more things we really want to get to. We are going to extend the time. Some of you may not be able to have that other 15 minutes, but hopefully many of you do. We hope you can stick around until 3 o'clock Eastern, the top of the hour. So thanks for that, Bruce. I want to move to April Odom. April is an advanced practice registered nurse with over 20 years of experience. She owns the health clinic Physicals Plus, which provides home-based primary care in and around Chicago, my hometown. Go Bears. Excited about the draft. April is part of a project of the Home Centered Care Institute known as HCCI. So April, the question to you, at least off the bat, is, and thank you very much for being here. I'm really glad that we have someone who's gone in and out of people's homes during the pandemic to share their thoughts. As someone who has done that, what do you feel like you've learned about what needs to happen next so home-based care really delivers for patients now and into the future?
Thanks, Dan. So what I think is, listening to this whole conversation with home-based primary care versus hospital at home, because they're different, as Bruce said. So I provide home-based primary care, and one of the things that I've hit barriers in is, occasionally I have those patients who are completely homebound and have difficulty getting out, but may need to get to a specialist. Like one guy I had who needed to see a urologist, and there's no services that's coming to the home. So if we can integrate these services and have more services to the patient, that would be beneficial for them, because, you have a patient at home, just him and his wife, who's, both elderly, and he had to get, two of his sons to get him up, to get him out the house. And then days later, he's, more fatigued. He's, having more tremors because he has other health. So it's just such a task to get out when we couldn't find ambulance service to take people to appointments, because that used to be a thing where you can call and say, hey, can you transfer my patient? But they weren't doing that during the pandemic. So that was one of the biggest struggles so far.
And what did it, how did you think about that? You shared that story with me in a background call a couple of weeks ago, April, about that man and his sons having to carry him and the toll it took. Like, did this sort of, in my mind, when I heard you say that to me, I was kind of like, oh, this is sort of a situation where it's kind of 2 steps forward and 1 step back. Like the 2 steps forward is like, okay, so this man and his family are now getting some care delivered to him at home, which is good. But when you need more, you're not getting what you need. And then it could go real bad, real fast.
Exactly, yes. And so that was part of the thing, is in having hospital at home where there are more services available would definitely have been, especially for this particular patient, a benefit, because then he wouldn't have to go out, because it was just such a struggle.
And what about the workforce, April? What have you learned during the pandemic that informs what changes need to be made there?
Well, for me, as a small business, I think, and I have an independent practice, so I have a clinic and I do home-based primary care also, but being able to integrate with the larger organizations where they, are more accepting, sometimes doesn't always happen. We've had, for instance, struggles with, I order a test for a patient. So I ordered a swallow study for a patient, for example, which is going to assess the patient's ability to swallow without aspirating, which means swallowing food or fluid into the lungs, which would cause complications. And because they didn't have me in their system per se, as they're one of their hospital providers, it took us a delay in time getting the patient results. And that means my staff is calling, days and days, which is, and so I think there really needs to be a good partnership, as I think it was Bruce or Mona said, integrating a lot of these services so that we can all work together for the better of the patient.
And final, thank you very much for sharing that anecdote. Can you, from a human patient perspective and from a workforce perspective, well, let me ask you from the workforce perspective. If it's not integrated the way you're just talking about right there, can you do your job? Can other businesses actually function? Is this actually gonna, without that integration, will any of this work?
I always say sometimes it's like a Band-Aid. So it works a little, but there'll be things that are lacking. There'll be things that are missing. And so in order to have a complete system where we have, everybody's working together, which is how it should be, patient-centered, we definitely need the integration.
Very good. Thank you very much for that, April. I'm gonna turn to the audience. I appreciate, again, thank you so much for being here. And I won't say that just because you're from Chicago. Okay. I'd like to go back to all of you and get your thoughts in here. And just like last time, we're going to ask you to raise your hand in the Zoom. And the question now is this: as you look ahead to the next 5 years, what is one challenge in your mind facing home-based care? And while you're raising your hands, here's what one person wrote in. Alex Cho from Duke University School of Medicine wrote, quote, "A lot will depend on payers." Looking at you, Mona, "it was disappointing that few to no private payers followed CMS's lead on hospital at home." Okay, and I see that, let's see, looking for a raised hand. And Juan, I may be mispronouncing your name. I apologize if that's the case. I see you raised your hand. If you could unmute and let me say the question again. And then this time, if you just introduce yourself, your name, your title, tell us where you're from, and then we'll go into it.
Great. My name is Juan No. I'm the Chief Medical Officer at Signature Healthcare Brockton Hospital in Brockton, Massachusetts. And I have a question.
Okay.
So the question is, I believe personally that this is innovative and will be pretty much standard care in the future. The challenges that I see are that there's no playbook. There's no standardization on how to set up a program. Because I want to set up a program at my hospital, but there's infrastructure, there's all the telemonitoring, and there's just no best practice that's out there, at least as far as I know. And I think that's a challenge. And if there was some way of doing that, I think a lot of hospital systems would proceed. I don't think it's strictly financial. I think it's just a lot of unknowns.
Juan, thank you. Thank you for perhaps the question of the session. This is essential. I really appreciate that. That's a wonderful thing. And Bruce, looking at you here, I think you might have some thoughts or something you can share with Juan.
Yeah, Juan, great to see you. I can't remember, we may have spoken on the phone previously, but good to see you. I think Juan's question is excellent and requires answering. Hospital at home developing in the US over the last 30-ish years. A lot of that initial effort focused on developing a prototype of a model and testing out, improving the effectiveness of the model. And then taking that prototype and then standardizing it and developing it and making it more cookie cutter and easier for health systems to adopt is something that I think many in the field are working on. And I think you're right. Making it easy for people to adopt the model is important. On the other hand, and that's something that the Hospital at Home Users Group, which is sort of an open source place for hospital at home technical assistance, we've been trying to pool and collect information from the hospital at home community to help move that forward, also developing program standards and seeing where programs measure up against those standards. And I think you've seen the entry of several commercial entities into the space. I do some consulting for some of them, so full disclosure, but I think they've actually been helping to create that more cookie cutter thing that makes it easier for health systems to adopt. I would say though that even though it feels very different, I don't think it's all that different from a lot of other innovative care delivery things that health systems build out. It is more complicated. There is a bit more on the logistics and the supply chain, but I think when systems adopted and implemented ICUs, there was that similar growth curve, except it was more familiar because it was all hospital based. And I'll let Mona chime in. I see her hand up.
You might be muted, Mona.
Yeah. I think one of the challenges that we should just be honest about right now is that health systems and broadly the healthcare industry is retrenching in many ways. And as people are looking at competing programs and priorities, folks have to make the business case in their respective organizations for a model like this, which requires an enormous amount of upfront investment. And so in my conversations with many different health systems, and I would say some of the top performing health systems that actually should have the resources, there are questions about, do they put their dollars in this program versus doing what they see as a core of their operations, where they know what to do and know how to be successful. So that's sort of why I was saying earlier on that I do think it's important for folks like us on the payer side to partner with health systems to say, which patients in which areas do we think could really benefit from this program? And then how do we collaborate to create that system? I think what is going to be incredibly inefficient for the space in general is if every individual within, many different health systems is making the case to their leadership on their own, and then putting in enormous amount of upfront investment to do a regional program. What I'm also hearing is that despite the good work that folks have done in this space for a long time, for many people who are doing this program right now, from a business perspective, they're not seeing that ROI. And I think part of it is about getting to those economies of scale. So I do think that we have to get a little bit more creative and think about those novel partnerships. I'm not saying that, I have solved that, but I think we do have to think about bringing stakeholders across the system to say, what are the strengths across each of us that we can bring together to build that system, rather than every system doing it on its own.
Just a real quick thing, and we've just got 7 minutes here left, so time is beginning to tick down. Juan, I'm just curious, were those answers helpful to you in what you're trying to accomplish, or if not, what is it that you feel like you need?
It's somewhat helpful. To start a program from scratch with no experience doing it is very difficult for a small independent community hospital. We're about 20 miles south of Boston. MGH, Brigham and Women's, and UMass have all started it. They're huge systems with a lot of resources. We're an independent community hospital. To have a playbook, basically, of this is what you need. These are the things you need to set up. These are the things you need to think about. It would make it a lot easier. I'm going to do it anyway, but it's just going to take me a lot longer.
And could you participate in that hospital at home user group? Would that be useful to you?
I'm on it.
Oh, okay, great.
Dr. Leff, you actually communicated with me on email, and I joined that group afterwards. So I'm on it.
Got it. Great. And thank you again. Thank you, Juan, for this. And Mona and Bruce, thanks for those responses to Juan's question. We've got some great comments in the chat. I want to read one. It is from Michelle Johnson. Hospital at home would be a great benefit to those homebound patients if the waiver did not require a visit to the ED or start in an inpatient brick and mortar. It would be great if that requirement was looked at as part of the CMS evaluation of hospital at home. Bruce, I see you nodding your head. You have, and just because we're tight on time, real quick, 1 or 2 sentences.
Yeah, the 1 or 2 sentences. That was originally put into the waiver because I believe CMS wanted to be sure that people who were entering hospital at home actually did require hospital level care. And they wanted to make sure the hospital was deeply involved in that patient's admission. And they wanted to, I think at some level, make sure that the folks who needed this were folks were getting this who actually needed it and were getting safe, high quality care. I think they were a bit anxious about, decoupling it from the acute hospital completely. I think that was a reasonable concern to have in the midst of a pandemic as they were launching this, and it might be something they could look at going forward.
Is that something you're going to be pushing CMS? Are you going to be lobbying them on that?
Pushing to think about it for sure.
Okay. Mona, anything you want to add there quickly? Okay. I've got another great comment from William. He says he'd be interested in hearing more about the economics of hospital at home, particularly who the winners and losers might be. also, what are the implications of a hospital at home for non-Medicare patients? Mona, I think that might be a great question for you, and not to put you or Humana on the spot here, but when you talk about winners and losers at a more broad general level, how do the economics shake out?
So I think if we are talking broadly about the whole spectrum of home-based care, in my mind, if you're oriented towards a system that is paying for value, then at the end of the day, you're paying for outcomes and the patient wins, right? Really, the question is, what's the upfront investment that's required? And oftentimes making that initial business case is the most challenging. But let me just give you a tiny example, and this goes to Bruce's point early on about integration. Pulmonary rehab, which we know to be an effective intervention for people who have a chronic obstructive pulmonary disease, so a lung condition, we know that to be effective. But those patients are at home and hard for them to get to that care. Now, we in our data as a payer can see that there are less than sort of single-digit numbers of patients who qualify for that service, who actually get that service. And wouldn't it be amazing to be able to offer that program for patients in the home? From a value perspective, there's value for the patient there. There's value for the health system because you're keeping patients out who don't need to come back, and you are creating value for the payer. So I think that you have to look for programs where you know those programs to be effective and match the patient population, and then provide those programs. And the math works out. I think it really is about targeting the right programs to the right population.
Very good. And we just got 3 minutes left here. I'm going to read one more comment, and then we're going to go to Bruce and Mona for just one sentence each. And then we're going to end it on you guys, the audience. It's from Almeida Russell, a friend of my mother's. Almeida, thanks so much. Also a supporter of Tradeoffs. You've been an incredible supporter this whole time. Thank you very much for being on the call. It means a lot to me on a personal level. Almeida says, wish it were an option, hospital at home, when helping to care for some of my deceased loved ones, many of whom simply did not trust hospital settings, especially my uncles. I feel like that's a poignant comment to make. Thank you, Almeida. Okay. Final thing. Bruce, we'll start with you. One sentence, and please just one sentence. What does home care look like in 5 years?
I think home care looks more integrated, more scaled, and hopefully will have taken advantage of the crisis, and as Mona said, not let reversion to the status quo ante take over.
Bruce, everybody, if you didn't know before, loves a comma. Mona, how about you? One sentence, what does home care look like in 5 years?
So I guess I hope that receiving care in the home becomes more recognized and accepted by patients, and that the demand is there, so that folks that can combine the right clinical model, technology, and caregiver support can actually meet that demand and accelerate the adoption of home-based care.
Very good. Thank you. Final question to our audience. One adjective about how you're feeling about home-based care right now. And I'll read a couple of them. Let me scroll down. I've got to get there. Joe, hopeful. Nick, righteous. John, hopeful. Julie Stone, optimistic about the prioritization and innovation coming this way. Almeida, scary but needed. Kara, research hungry. I love a hyphen, hilarious. Thank you all for saying that. And I'm just going to say real quickly that this has been a wonderful conversation. 2 words that I have circled in my notebook are integration and voice. Integration of services, voice. I guess I also should talk about, though, I think caregivers and what are we actually asking other people to do, and how well equipped will they be to do that. And I also want to flag that comment from the top about cultural fluency, walking into someone's home, becoming a part of their family, doing that well, making that seamless, making people feel safe in their own homes. This is a big deal, people. This is a big deal. With that said, I'm so glad that you all enjoyed today's conversation. I hope if you have not already, we hope you check out our reporting on Hospital at Home. The link is in the chat. We drop new reporting each week on everything from drug prices to health equity. So please make sure you are subscribed and stay in the loop and learn about future events. Tradeoffs.org/subscribe. We're really proud of this small and humble but important media organization that we've created here. So with that, I'm just going to thank everybody. I really appreciate all y'all taking the time, especially Melanie and April, Mona and Bruce, and to the entire team, particularly Krista and Jim. You guys have been amazing and incredible, and we are all very lucky to work with you. Thanks, everybody. Have a good weekend.